afternoon, and welcome to the Lynn Cancer Institute's physician presentation entitled A New Dimension in Radiation Care, Proton Therapy at the Lynn Cancer Institute. It's my pleasure to introduce Dr. Robert Press, our physician director of the LCI Protein Therapy Program here at Lynn Cancer Institute. Dr. Press is a recognized leader in radiation oncology with extensive expertise in proton therapy and a deep commitment to advancing precision cancer care. Dr. Press will provide clinical and strategic leadership for our program, guiding multidisciplinary teams to deliver highly targeted, patient-centered treatment while driving innovation, research, and program growth. Lynn Cancer Institute's dedication to clinical excellence and compassionate care continues to shape the future of proton therapy and improve outcomes for our patients. In the interest of time, Dr. Press's bio was sent to you by email. During his presentation, we ask you to please take notes, and you can add your questions or comments in the chat box or in the Q&A box. And at the end of his presentation, he will be able to address these questions. With that being said, I'm very pleased to welcome Dr. Press to our community and to introduce him to all of us. Dr. Press.
Great. Thank you, Jan. It's a pleasure to be here today, and thank you for that kind introduction. I'm excited to discuss with you a little bit about proton therapy, exactly what it is, and where we are right now and where we're going. It's a very exciting time, both in the field of radiation oncology, but also at Lynn Cancer Institute, as this new technology is getting currently commissioned and will be operational very shortly. And so without further ado, I'll jump right in. I don't have any disclosures to report. As we go over this, there are a few objectives I'm hoping that the audience can take away today. The first, most important, is just what is proton therapy and how does it differ from conventional X-ray or photon radiation? You'll hear me referencing that a lot. Recognize the current access and utilization around the country, what that has, how that has evolved and how it is today. Then identify which patient and tumor types are most likely to benefit from this therapy, and give you a brief overview of that. And then I will dive into some of the latest clinical data in some select disease sites, and talk about some ongoing trials. In general, this in oncology, we're very data driven. I think for most of the audience, you can take the big picture away from the data that I present, but I think it's important just to show you exactly how we're thinking through proton therapy and the data and how we interpret the trials. And then it's also very important to appreciate some of the limitations of proton therapy too. So I'll have a slide or two about that, and what are some of the nuances of proton therapy. And so with that, we'll jump right in. So, so about half of patients who are diagnosed with cancer actually receive radiation therapy in their during their time of their diagnosis. We at LCI have the privilege of a very wide array of radiation technologies. Some of the most diverse and capable machines, of really any cancer center. We really rival that. And now with the addition of proton therapy, really have solidified the radiation portfolio. And what this means for patients is that we're able to then personalize the treatment plan into the treatment, radiation treatment modality decision to employ the optimal modality for a specific patient's diagnosis. It's not a one-size-fits-all approach, and we have all these different tools in our toolbox to employ for the right patient at the right time. So what is proton therapy? So I want to make the point that proton therapy is still an external beam radiation treatment. So it's still a beam of energy that comes from the outside into the patient. and delivers ionizing radiation to damage tumor cells and cause them to die. It's a local treatment. And this is similar between proton therapy and photon radiation. Now, the difference is what makes up that beam. So if you look at this high school physics textbook figure here at the bottom, you look at electromagnetic waves and X-rays. That is the type of radiation that is used in conventional photon radiation. These are the same X-rays that you use when you go and get a CT scan or a chest X-ray. And the nuance of this is that the X-rays penetrate the body completely. And so you'll hear me talking about how we take advantage of this difference with proton therapy. But that's how X-rays are delivered. When you get a chest CT, they have to put a detector behind you when they image you, and the X-ray goes through the body completely, and that's and picked up on the detector, and that's how we get scans. So we use that same type of radiation for cancer treatments, and that has been the standard, radiation treatment for decades. Now, proton therapy is a beam of energy that uses the proton particle. So this is one of the building blocks of the nucleus of an atom. We isolate that, we speed it up near the speed of light, and then we direct it at the patient. Because it has a physical mass and a charge, it has very different physical properties. And the key concept to take away here is that it has a finite range in the tissue. So proton beams or X-ray beams go all the way through the patient. Proton beams go a certain distance and then stop. And you'll see that this can have a profound clinical impact. So really quickly, not to be too confusing, but to focus on photon therapy real quick, you can see here that this is a linear accelerator for photon or X-ray radiation. You can see the table where the patient lies. You see the contained LINAC or linear accelerator kind of all in one unit that's within the patient room. It generates the radiation on its own, and it's all kind of contained in a single room. With proton therapy, it's quite different. The patient experience might look the same. You lie on a table, you can see the nozzle there over the patient, it's still an external beam that transverses into the patient. But behind the scenes, it's a much larger operation. The source of the proton particle is actually isolated from hydrogen gas, and then is accelerated in this large, nearly 100-ton cyclotron, which you can see in the top right image being installed at one facility in the USA, and then is steered into the patient with this large gantry, which is the bottom right figure, using magnets to bend the beam. And so in order to accomplish all this, you can see the large infrastructure required, why it takes so long to install and to commission and to run the machines. It's a much more complicated operation. So how has proton therapy expanded across the USA? It's not necessarily a new therapy. They've actually been treating with proton therapy clinically since 1990, with the first center opening in California. But since then, you can see here, looking at the dates, that the proliferation of center growth has really dominated in the last 10 to 12 years. You can see that the Proton Center at Miami Cancer Institute, as part of Baptist Health, opened in 2017. And our cancer center opening, our Proton Centers in the near next few weeks to month, will be the 50th operational center in the United States. So, that sounds like a lot of centers, but if you think about the entire country, the entire number of cancer patients, in the USA per year, and you can see on this map the distribution, there are still large gaps where proton therapy is not available in certain parts of the country. You can see it in the tri-state area. In Florida, there's kind of the highest density, but as particularly as you get to the Midwest or West Coast, the number of centers is really limited. So it really is a limited resource. when we talk about, so not to get too into the textbook here, but when we look at how that dose is distributed, this is kind of the classic figure showing that X-rays in the blue line as it goes through tissue on the x-axis, has a buildup and then attenuates throughout the patient and has that exit dose, which is that right orange block on the right side. And so that's the exit dose that is not seen in proton therapies. Proton therapy, the beam comes in, we treat the tumor to a certain depth, and then the dose falls off. So really that orange block on the bottom right is what we're eliminating with proton therapy. This is a phenomenon where that dose falls off called the Bragg peak. This is seen a little more clear in this figure. The top green figure is kind of a path of the beam, and the blue spots are the ionizations, or where that energy is being deposited. And if the proton beam energy is high enough, it passes through without delivering much of its radiation. And as you can see, as that blue dotted line goes down, the energy of the proton beam goes down as it gets further into tissue. Eventually, it reaches a threshold where then exponentially those ionization, the rate of ionization increases, and you get a lot of those blue spots on the far right of the green figure, kind of delivering all that dose in the tissue at the depth that we want. This is what proton therapy is and how we take advantage of that. Now, how is the beam actually delivered? So we're actually on our third generation of proton therapy. This is called pencil beam scanning, and this is what we have the latest and greatest installed at LCI. Basically, the beam is individual spots that we place at different depths in the tumor that's steered by magnets. So magnets can move things with positive and negative charge. Protons have a positive charge, and we're able to steer the dose along the path of what we want to treat using these magnets, and it kind of paints the layer by layer. And what this looks like visually, for example, in this lung tumor, is you start with the most distal layer and you're painting across the tumor as it's coming back. And you can see, even though the beam comes in from the left side of this image, the distal end beyond the tumor is receiving essentially no dose because the dose falls off. And this is the dosimetric advantage that we take advantage of in proton therapy. Now, before I go too far, I did want to just make the point that photon radiation, modern state-of-the-art photon radiation, can still be a very effective and important treatment for some patients. And the way that we deliver the radiation when the dose goes all the way through is we essentially treat from multiple different angles. So this is a schematic of a head and neck treatment plan. And you can see that in those red dotted lines that are going around the patient, the beam is actually being delivered in an arc all the way around the patient. And what that enables us to do is focus the radiation in certain spots and conform the high dose. But what you're going to see is that there is a low dose or moderate dose spread around the patient. And so on the figure on the left side, this is a representative photon plan using the ARCT method. And you see that low dose haze of that kind of darker and lighter blue, whereas the red high dose area is still very conformal. This is the conventional photon X-ray radiation method. And you can see the difference with proton therapy. In proton therapy, instead of arcing around the patient or treating from numerous angles, we typically select around 2 to 4, 2 to 5 angles that are most optimal, and we treat just from those directions. And so what you're seeing is that the dose distribution is a much more tailored, is much more tailored, and you don't have that low dose spread throughout the body. Now, how does this difference translate to you as the patient, and which patients are the kind of the optimal patients for proton therapy? People will often ask, can we treat this with proton therapy? And the answer is typically yes. We can treat, head to toe, and there is a long list of tumors that we treat. But when we think about patient selection or optimal patient selection for a limited resource, we do have to try and identify the patients that are going to benefit the most. And so when we think about those patients, there's kind of a list of different criteria. Nothing is hard and fast, but it is important to think through this. And everyone has a different, scenario, a different diagnosis, a different stage. So it's important to personalize that decision with your physician when you're thinking about whether or not proton therapy is right for you. Some of the most important criteria, so generally age, and this is really most relevant for our pediatric patients. So when children have cancer and they need radiation, we, kind of understandably want to limit any unnecessary radiation or any treatment for a child, especially as they're developing and their body is still growing. Radiation can have greater impacts on them. The flip side with age is that if a patient is much older, and let's say that they're more frail and they have less ability to tolerate therapy, then trying to spare unnecessary radiation, reduce the intensity of the side effects of treatment might be a big gain in that patient population as well. So kind of the extremes. Disease sites, there's certain disease sites that I'll highlight later on that have kind of the most evidence to support this clinical benefit. There are some that are still under investigation. And so depending on the diagnosis, it can make a big impact as far as whether or not proton therapy is optimal. The extent of disease. So if someone has localized disease and is being treated with curative intent, and we have a good chance of that outcome, and they have a long life expectancy, those are the patients that likely will have a longer time to benefit from the less intense treatments of proton therapy. If someone has widely metastatic disease, then they might not be the best candidate in certain scenarios because the treating with a more advanced local therapy might not have as great an impact overall on their overall outcome. So it really does depend on the extent of disease, what we expect the outcome to be. Then also, where is the tumor that we're treating? If the tumor is in close proximity to very important critical organs that we're really trying to spare, or if they've had a prior history of radiation therapy, and we know that giving a second course will lead to higher cumulative doses, then using this advanced technology can really have a big impact. And so those are kind of the main criteria. Ultimately, the goal of proton therapy is to try to widen what we call the therapeutic ratio. We're trying to primarily minimize toxicity in most cases, and in select cases, trying to actually improve the tumor control. So what we are doing is threading that window that between doing good and potentially causing a side effect. So I'll jump into some different disease sites here. We'll start with pediatrics. Now, I'll go over this kind of briefly, but in general, this is one of the most well-established disease sites or clinical scenarios where proton therapy is considered the standard of care. This is specifically just looking at pediatric brain tumor patients, but what we see is that majority of patients do have long-term survival, but that means that those patients, particularly developing children, can be at risk of developing late effects of treatment to a much higher degree. And we see things like cognitive impairment, hearing loss, hormonal imbalances affecting growth and fertility, and also radiation-induced second cancers, which typically take roughly 10 plus years to develop. But in a child, that could still be a very likely scenario. And we see that from this large historical childhood cancer survivorship study, that nearly 2/3 of patients with brain tumors still developed severe, we call grade 3 chronic side effects or adverse events, after their curative treatment. And that even about over a third of childhood cancer survivors could not finish school or hold a full-time job. So they're having, even though we're curing a lot of children, which is great, they're having a lot of fallout from the treatments that can affect their quality of life. So, and then we look at survivorship by 30 years. And you can see clearly there's a significant decline in survivorship for pediatric cancer survivors. And we look at what's the cause of this, even though that even if their tumor is controlled, oftentimes there can be second malignant neoplasms that develop either because they're at high risk of these things from developing, or the radiation treatment itself might induce that kind of side effect. There's can also be other cerebrovascular events or other effects on their neurocognition that lead to worse quality of life or lifespan. So we know that reducing dose to pediatric patients is critical. As I said, that proton therapy for pediatric patients is the most well-established standard of care treatment for any disease site. And you can see the list of all the different tumor diagnoses where proton therapy is commonly utilized now. Moving on to adult brain tumors. So this diagnosis of chordoma or chondrosarcoma, which is a primary bone tumor that arises often in the mobile spine, is another classic indication for proton therapy. These are typically radioresistant tumors that occur in very difficult, locations near very important critical neurologic structures like the center of the brain called the brainstem. And traditionally, even with advanced photon radiation, there has been difficulty achieving an adequate dose to control these tumors without overdosing normal tissues or causing severe risk of side effects. And so oftentimes with photon plans, we have to underdose or undertreat the tumor to meet certain constraints. Proton therapy in this kind of scenario where you have a need for a high dose next to a very critical structure really shines. And you can see here, this is a case of a 37-year-old who had a base of skull chordoma that was treated with surgery and then is now being treated with postoperative proton therapy, and hugging the dose curves, which are those thin lines around the central part of the brain, which is highlighted in the orange line. You can see how we take advantage of these dosimetric differences to really put a high dose and spare lower dose to the brain stem. So this is another area where we've seen the ability to dose escalate with protons has really shifted the curve to improve local control rates. And this is translated on meta-analyses to improved outcomes in survival compared to photon radiation. When we switch gears to primary brain tumors, proton therapy typically is mainly utilized for lower grade gliomas or primary brain tumors. These tend to occur in younger patients, tend to be more slow growing and more responsive to treatments. And the reason why we consider proton therapy for these types of patients is that they tend to have a more favorable prognosis and can be at risk to develop those late effects, more likely. And so even though adult patients with these types of tumors have already completed most of their development and are no longer at the same level of risk as pediatric patients, we know that cognitive dysfunction after brain radiation is still a real event that can happen in adults. It can affect things like short-term memory, your processing speed, your attention span. And we know that there's certain areas of the brain that are more eloquent for memory that can be more deeply affected. We now have level 1 evidence showing that if you selectively reduce dose to certain parts of the brain, that can reduce the risk of long-term cognitive dysfunction. And as I mentioned before, in the pediatric population, this is clearly demonstrated with very high-level evidence where patients treated with proton therapy had much better preservation or at least reduced decline in their IQ compared to the patients treated with X-ray radiation at a similar duration. So there is now prospective evidence supporting the use of proton therapy for low-grade gliomas and its ability to preserve cognitive dysfunction. These are kind of just all different types of cognitive tests that we ask patients to fill out. But you can see in general that the bars are in a similar place, and this is up to 5 years of follow-up. And so the ability to spare the normal brain from unnecessary exit dose radiation might have a major advantage for these patients long term. And for example, despite a nationalized healthcare system, even the Netherlands, for example, has concluded that proton therapy is now the standard of care for low-grade glioma. And we commonly will offer that treatment for these patients if we have proton therapy available. There is a large national trial called BN005 that recently completed accrual. That's kind of the definitive phase 3 trial examining just what the magnitude of benefit might be when we compare proton and photon therapy for favorable gliomas. Now, switching gears a little bit in the CNS or the brain space. I did mention that in general, patients with metastatic disease might not benefit as much from proton therapy. However, there is one unique scenario where this really, is kind of flipped upside down, and that's for a diagnosis called leptomeningeal disease. Now, this is still a very serious diagnosis. Where the cancer cells not just are in the brain, but actually in the fluid-filled space around the brain and spine, called the cerebral spinal fluid. This is, advanced state of disease. It does carry a very poor prognosis, and typically patients only live a few months once this diagnosis is identified. And the typical standard of care to using radiotherapy is to treat the areas where we are seeing the most symptoms. So if the patient has this in the brain, kind of around the outside of the brain, we would treat the whole brain with radiation. Or if there's a focal area in the spine that's causing symptoms, we would treat that selectively. Now, there's a technique called craniospinal irradiation where you treat the entire brain and spine all at once. And the goal of this would be to try and sterilize the entire brain and spine compartment, all that fluid that's at risk of this cancer. Typically, though, when you treat this large of an area, there are concerns about toxicity and ability to tolerate further therapy, effect on your bone marrow and your immune system. So typically, this has not been employed. However, with proton therapy, you can see on the figure on the right that the anterior compartment, including the heart, abdomen, and bowel, is completely spared of radiation when we use proton therapy compared to an X-ray plan. And so similar to pediatric patients who sometimes need this craniospinal approach, for adult patients with this severe leptomeningeal disease, we can offer them a better treatment with similar toxicity. And there's now been a phase 2 randomized trial that compared the two techniques between proton craniospinal radiation and photon involved field radiation and identified a nearly 5-month, a nearly 4-month survival advantage using proton therapy to use this technique. And so for patients with this devastating diagnosis, we can offer them a treatment that can gain them significant more time, which is a really rewarding thing to do. Moving on to my next disease site, I'd like to talk about head and neck cancers. So head and neck cancers, cancers of the kind of mouth, the back of the throat, and the voice box are a common disease site that we treat with radiation. It can be a very kind of difficult treatment that we ask patients to go through because they're often getting concurrent chemotherapy, and then as you can imagine, the mouth and the throat area is very sensitive and can be very radiosensitive, and so we end up seeing a lot of side effects, which we typically manage, but of course there's no extra points for suffering, and we want to try to minimize those side effects as much as possible and still get patients through the treatment. I'm going to focus on a subsite called the oropharynx, which is basically the base of tongue, or the tonsils, which is the kind of the most common site that we see throat cancers today, and often mediated by the HPV virus. And so this is what a head and neck cancer radiation plan looks like. You can see that on the left side is an CT scan. You can see the jawbone there. And you can kind of see on the on the figure's left side, where we're trying to put the dose with those colorful lines. And conventionally, we would have exit dose going through the front of the mouth, the lips, the teeth, and this can lead to more brisk and diffuse mucositis or irritation of the mucosa. And with proton therapy, as we place beams kind of on the posterior obliques from both sides, we're able to blur that dose, but stop the dose prior to exiting through the mouth. And we sometimes see these kind of dramatic demarcations of where that dose is. You still have to put the dose on the area where the tumor is, or you're trying to spare all that healthy mucosa beyond that. And this difference between a diffuse picture of mucositis or a more focused picture of mucositis is now showing in a lot of studies that this can help reduce overall toxicity burden and help patients have a higher quality of life during and after treatment. As I mentioned, when you get chemotherapy, the toxicity or the potential side effects is elevated. We give chemotherapy radiation because we know it works better. It helps the radiation kill the cancer better, but we know that that means that some patients are going to have more side effects. There's now been a large study that was conducted at the University of Pennsylvania that looked at all the patients who had locally advanced cancer diagnoses getting chemotherapy and getting radiation. And they broke it down by the photon X-ray radiation group and the proton group. And what they showed in their propensity scored analysis was that patients who received proton therapy had a dramatic reduction in those really high or severe grade 3 or higher adverse events. That would include things like unplanned hospitalizations or need for a feeding tube while on treatment. And importantly, they did not see any difference in disease control or survival, which is would not necessarily be expected to be affected just by the change in the radiation modality. So what we're seeing is that proton therapy can have a potentially even greater impact when the toxicity of the treatment might be higher than other types of treatments. There was now been a published phase 3 randomized trial that was started at MD Anderson, specifically looking at locally advanced oropharyngeal cancer patients treated with either proton therapy or photon therapy while getting concurrent chemo. This actually just came out this year in the Lancet, which is one of the largest, kind of highest impact journals. And they had 440 patients enrolled. Majority of patients in this study were around the age of 60, male, had HPV or P16 positive disease. So this is kind of the typical patient population that we see in the USA with oropharyngeal cancers. And importantly, they showed that proton therapy treated patients had a significant reduction in acute and late side effects, particularly things like severe problems with swallowing, dry mouth, and effects on their blood counts. In addition, the need for being on a feeding tube during this time was dramatically reduced, about a 33% relative risk reduction. And so this is very impressive and supportive evidence that proton therapy can have an impact on these patients. What was surprising was when we looked at the clinical outcomes data. So not just the toxicities, but how did the actual tumor control or survival do? Now, again, we don't expect there to be a difference in tumor control because we're still treating to the same dose to the same regions. And that's what was shown in this study, that the progression-free survival, or how long did patients live without disease recurrence, did not seem to change between the two modalities. But what was surprising is that when we looked at survival at 5 years, there actually was a survival difference. And in fact, it was actually quite significant, about 10% absolute survival difference, or around 58% hazard reduction with the proton arm. And this was not an expected finding, but is an important finding. And the hypothesis behind this was, well, maybe if we're reducing some of the severe late treatments related side effects, particularly things like chronic radiation fibrosis, that can worsen your swallowing and make you at risk of aspiration and pneumonia. Maybe this is causing a change or affecting the kind of post-treatment course for patients. That might also have a less effect on the immune system because less normal blood cells are being exposed on a daily basis. So this is another hypothesis. But overall, this study was very impactful. There have been some other studies recently that don't show quite the same effect, but overall, the evidence is moving in the direction where proton therapy is the new standard of care treatment for head and neck cancers, at least as a standard of care option. And so this is an area where further investigation is going to be important, but is already showing great promise for treatment of head and neck cancers. My next disease site I wanted to talk about is breast cancer. So, in general, the most common cancer for women, it's typically treated with surgery and chemotherapy and radiation if you don't have a mastectomy. And we know that women can do well with this treatment. The survival rates for breast cancer are going up. Patients are living longer. We're having better systemic and hormonal therapies. And what we're seeing, though, is that at long-term follow-up, that some women, despite being cured of their breast cancer, are seeing higher rates of cardiac events like heart attack, MI, needing stents, arrhythmias. And so, we're seeing that could impact that survivorship. There was a landmark study published in the New England Journal in 2013 that correlated that the mean dose to the heart, so the average dose that gets put around the heart, has been correlated with a very specific 7.4% relative increased risk of cardiac events for every 1 gray increase. And the important thing is that there's no threshold to this correlation, meaning that if you had 10 gray to the heart, then your relative risk of cardiac events could go up relatively 70%. This could have a major impact on women who have survivorship for 10, 20, 30 plus years. And so heart dose is becoming more and more important, particularly for disease sites like breast cancer, where patients can have long-term survivorship. You can see on the right side of this figure a kind of a traditional X-ray or IMRT plan. And what you're seeing is that the breast itself is the target, the tumor. But there is this kind of overlap between the heart and the modest level of dose you can see circled here. And what we know is that dose, even though it seems very small, can have a major impact long term. And with proton therapy, we're able to better shield the heart, particularly for left-sided breast cancers. On the right side, it's not quite as much of an issue, depends on the scenario, but particularly for left-sided breast cancers, sparing that little sliver of the heart better with radiation could have a major impact long term. There's now solid evidence growing that when you do the dosimetric comparisons, that proton therapy generally can reduce the overall heart mean by several gray. So gray is the dose unit that we use. Mean heart dose in this study for protons was 0.5 gray, so less than 1 gray. Whereas for photons typically is around 2 to 5 to 6 gray, depending on the technique used. And that's just for the mean of the entire heart. It's actually growing more and more important to look at the sub-segments of the heart and specifically certain arteries of the heart. So the LAD, of the left anterior descending artery, is kind of the main highway for blood flow through the coronary arteries, particularly to the left ventricle. And this is important because it runs right through the AV groove along that kind of anterior position along the heart, right underneath the chest wall. So even though the mean heart dose might only be, maybe 5 times, the change, because the LED might sit in that high dose range, it might see a 10 or even 30-fold increase in heart dose depending on the technique. And these are the substructures that we know can have accelerated atherosclerosis and increased inflammation related to the chest wall radiation. And this is where we could potentially make a big impact. And so, as far as evidence generation, there's a now completely accrued large multi-institutional phase 3 trial called the RADCOMP study that specifically looks at this question for women with left-sided breast cancer who are getting that comprehensive radiation to the left side, and looking at the primary outcome of major cardiovascular events. So currently this study is still maturing, but it will be kind of the definitive study looking at the role of proton therapy for left-sided breast cancer. And then the last topic I wanted to touch on is reirradiation. So not a specific disease site, but more of a clinical scenario. And what reirradiation means is that we're giving radiation a second time after an initial course. Now, why would we need to do that? So sometimes patients might have treatment, but might have a local regional recurrence, and now they have active cancer again in the same region that we treated before. Or sometimes when we use radiation, again, in rare instances, but can happen, that there might be a second primary cancer that develops in the same area. Or if someone just has risk factors for a lung or head and neck cancer, for example, like smoking, even if you cure them from one tumor, there might be a risk of a second tumor. So we run into this scenario more and more where patients are living longer despite their original diagnosis, but now they have another need for a second course of radiation. And historically, we have shied away from using reirradiation due to concerns of severe toxicities. We have a certain risk threshold that we use as physicians, and in general, radiation oncologists are very conservative. But when we do a second course of radiation, we know that there can be, very severe side effects in certain, small rates of patients, and so we don't take that lightly. Now, when we have proton therapy available, because of this ability to really limit overlap with prior radiation, limit that low and medium dose spread, we're able to, look at this with a finer tooth comb and potentially provide, an opportunity for a second aggressive treatment course. And this might render patients who were previously untreatable to become treatable again, or at least more aggressive local regional treatments. The way that we look at that what we plan is we actually incorporate the prior radiation plan with a current plan, and we overlay them together so that we can pick an optimal approach and an optimal modality to try and treat the second tumor while still accounting for all the radiation they've received in the past. So we're starting to do this more and more. In fact, reirradiation is another kind of bread and butter scenario for proton therapy because of that distinct dosimetric advantage. And we're able to do eloquent planning where we can incorporate all the different radiation they've received and account for all these different factors in trying to deliver the safest plan possible. There is now growing evidence supporting the use of reirradiation in different disease sites like head and neck cancer, breast cancer. You can see that there are various rates of high-grade toxicity. It does not come without cost, but again, for patients who have limited other options, and this is another opportunity potentially for durable control, if not cure, these are risks that many patients are willing to take. This is another study looking at GI cancers, so esophagus or gastroesophageal junction cancers, and again, showing that there can be higher rates of local control than expected with modest, potentially acceptable toxicity rates. Now, the brain tumors are near and dear to my heart. We do have a clinical trial that's open in the Baptist Health System, specifically looking at proton reirradiation for glioblastoma or other glioma primary brain tumors. So these are patients that typically have recurrence at certain time point, and often are treated more conservatively at the time of recurrence, and often, not offered aggressive reirradiation. Now we're trying to change that, and looking at using proton therapy to more aggressively irradiate primary brain tumors. And we're using a technique, an additional technique in addition to proton therapy, to try and reduce the risk of late effects, called pulse reduced dose rate. Basically, we're giving the dose more slowly to allow for normal tissue repair. And so combining these two efforts, these two techniques, trying to improve outcomes for primary brain tumor patients who have recurred, potentially allowing for a safer way to dose escalate and provide better, more durable control for their tumor. And this trial is open now at Baptist Health, at Miami Cancer Institute, where we already have proton therapy active, and we're planning to open this trial as well at Lynn Cancer Institute in the very near future. Now, with my last little bit of time, I wanted to highlight some specific proton therapy limitations or challenges. So, nothing is a silver bullet, and because of this more involved, complex, treatment infrastructure, and the more complex physics behind the proton particle, there are certain challenges when it comes to proton therapy that we should be aware of. So first, it is just more limited access, as you saw in the map previously. It is a limited resource. So again, certain patients might benefit more than others. But when you look at the actual dose distribution, or how it's deposited, proton therapy as a particle is more sensitive to differences in tissue or setup errors or motion of the tumor. And so we have to account for that in our planning. And so, for example, if you look here in this figure on the right, there's a complex tumor shape that's kind of an L. And let's say we're trying to avoid the red structure as much as possible with the radiation. The way that we typically treat this with proton therapy is we'll put fields from different angles, right, to cover the entire tumor. But if we have a change in the tissue density or the path of the tissue with something, say, metal or bone that wasn't necessarily there originally, this could have a big impact on how that dose is distributed and essentially pull back the dose and undercover the tumor. So we try to overcome this by careful planning. We also, when we do the planning process, use what's called robust optimization, so accounting for different scenarios. And then when patients are on treatment, we do frequent reevaluations, called QACTs, to double check to make sure that there hasn't been any major change in the anatomy that we need to account for. So while you're on treatment and before and during the planning process, it is a much more involved process, an active process for the patient. In addition, because of the complexity, there can be machine downtime. Typically, a linear accelerator, if it goes down, it doesn't affect the other 5 linear accelerators in the department because they're all kind of self-standing. But in a multi-center proton department, if the cyclotron or the source that creates the proton beam goes down, then all of the machines go down. So there can be some more technical difficulties. Similar to my previous statement about the tissue density, if there's surgical hardware in place, that can also make it more challenging because the beam doesn't transverse that as well as it does with X-ray radiation. And then we are finding out more and more that the very end of that range of the proton beam, where it deposits the very kind of last, most distal portion of the dose, might have a different biologic effect on normal tissue in the tumor. And so what we're trying to do is understand that better and take advantage of that, where we're trying to put that what we call high RBE, or where the dose is maybe more effective than the nominal dose, trying to put that in the tumor and be more effective while sparing it from normal tissues. So we're learning this part of the biology behind proton therapy more and more, and it's an area of active investigation. So I say all this not to demean proton therapy, but just to put it in appropriate context that it is a very important tool with very impressive advantages with how you deposit dose and how you can spare patients from severe side effects. But it is more challenging, it's more complex, and that all requires technical expertise like we have here at the Cancer Institute. So between not just the physicians, but heavily rely on our physics team. There's also a dosimetry team that generate the plans, and then the therapists who are actually putting the patients on the table every day and treating them. You need expertise kind of from the top down in order to manage all of these different intricacies and nuances and deliver a high quality radiation plan. So with that, I finished my slides. I wanted to conclude by stating that proton therapy has very distinct dosimetric advantages, and that the data is rapidly growing and in many areas has been very impressive. We're very excited to have this technology here and offer it to the patients in our community. There is now well-established evidence supporting proton therapy as a standard of care for pediatric patients, for brain tumor patients, head and neck cancer patients, reirradiation. And there's growing indications and growing evidence in breast, GI, lung cancers, and even genitourinary like prostate cancers. I didn't have time to touch on everything today, so if anyone has some questions, I'm happy to about other disease sites I did not touch on. I'm happy to answer any questions if you put them in the chat. And the last takeaway, proton therapy can be particularly valuable for patients who might be younger or have good prognosis, who might be older, who might not be able to tolerate more intense treatments, or patients who have had prior radiotherapy, potentially offering a second chance for an aggressive treatment and even cure. So with that, I will stop and take any questions.
Dr. Press, can you see the questions? They are in the Q&A box. If not, I can read them.
Yes, I do. So I see one question here, so I'll just read from the top to the bottom. So does Cleveland Clinic have a proton therapy machine? I didn't have time to see that on the slide. So currently Cleveland Clinic does not have protons, and there is a proton therapy center being installed at the sister institute in Cleveland University hospitals. So there is going to be access in Cleveland, but Cleveland Clinic specifically does not at this time. The next question is, do you still recommend prophylactic feeding tube placement as we do in photon treatment, or do you wait and see with head and neck patients on proton therapy? So this is a great question. So when patients are getting that radiation and chemotherapy for head and neck cancers, we expect them to have difficulty with swallowing and their nutrition, and maintaining that is so critical to getting you through that treatment course. Your body needs all that energy to recover every day. And when patients lose their nutrition, they can kind of have a snowball effect and really can crump. So it's very important to maintain nutrition. Now, in most cases, I don't start with a prophylactic PEG tube if we don't need to. And what would necessitate that? So if a patient was presenting for treatment, but already rapidly losing weight or already had dysfunction of their swallowing, then that's a patient that I would put a prophylactic feeding tube in because we already know that they're in trouble. If a patient's maintaining their weight and eating orally, and unless they have maybe a really large tumor or a location that would be particularly challenging, I don't jump to put the prophylactic the tube in prophylactically, particularly with proton therapy. So it depends on the scenario, but we like to try to avoid it. And it's important to monitor your patient's weight during the treatment course to see if there's a threshold, typically around 10 to 20% of weight loss, where we would put it in. So the next question is proton therapy suggested for stage 2 prostate cancer, Gleason score 3+7? If so, what are the side effects and what if cancer returned? So, and then there was another follow-up question, but let's start with that. So I didn't touch too much on prostate cancer specifically. Prostate cancer has been well studied with proton therapy. There was now been a couple large comparative trials that have been published. In general, proton therapy is a very effective treatment for prostate cancer. The chance of tumor control is compared to X-ray radiation is essentially the same, if not even a little better. But overall, it depends on the scenario for prostate cancer to see what the kind of maximal benefit might be. So if you have lymph nodes, for example, that need higher doses, or we need to treat the lymph node chain kind of up through the abdomen, pelvic area, then those are the scenarios where we often will see proton therapy utilized for prostate cancer. If we're treating the prostate as itself intact, that has, I guess, less strength behind that recommendation. It's certainly not wrong to be treated with proton therapy, but in general, might not see as much of a difference compared to X-ray radiation. It really depends on the specific scenario. Patients have other comorbidities, other medical issues, and depends on what their urinary function is, what their sexual function is, and so it's really important to have that discussion with your radiation oncologist, and talk through whether or not proton therapy would be, it would be best for you. It certainly would not be a wrong treatment by any means for any prostate cancer patient, but whether or not you would have a greater magnitude of benefit. One area where prostate cancer treatment, could make has a stronger rationale is if you are limiting some of the unnecessary X-ray radiation to the pelvis. So what that might help reduce is risk of, again, either late effects or secondary cancers that might develop 5, 10, 15 years down the road. If you're 105, that might not make a big difference. But if you're a younger man, then that is a potential risk that should be discussed with your radiation oncologist. And then it said, could the mass be removed or would it require more proton therapy? So that's a question of whether surgery versus radiation for prostate cancer. In general, that's a little out of the scope of this talk, but typically those are two viable treatment options for prostate cancer, and it's important to talk to your urologist and your radiation oncologist before making a treatment decision. Can Dr. Press discuss the challenges of constructing and equipping LCI's Proton Center? How does this reflect LCI's commitment and where they are in the process? Yes. So it's a big endeavor to open a Proton Center. I think if anyone's been following along, this has been a project in the making for many, many years. There's a number of difficulties with opening a Proton Center, and there's a reason why there's only 50 in the country. The primary issue is just the capital investment. It's a very expensive treatment. You have to build a whole new building. You have to build very thick concrete walls. The machine itself is very expensive. And so, typically when centers were being built out with multiple rooms, it was prohibitively costly to open a proton center at either a community hospital or private practice. Now, as all technology does over time, becomes more affordable, more efficient. We are now seeing single vault centers that are much more reasonably priced, that are opening throughout the country in a center like at Boca Regional Hospital and Baptist Health and Lynn Cancer Institute, for example. But even some private practices are even opening proton therapy. So the barriers to entry are being improved as the technology matures, and it does just show how committed LCI is to this technology, and where we think the field is moving, and wanting to offer the most cutting edge technology to our patients in the community. And where are we in the process? So we have installed the machine, we have accepted the machine, and we are currently undergoing what's called commissioning, which is basically where the physicist works nonstop to ensure that all the measurements are accurate. So before we put a patient on the table, we need to confirm that the treatment is going to be delivered accurately. And there's a whole list of items to do for commissioning before we can start. But we are making great progress, and we have a good timeline, and are hoping to get patients going with with proton therapy planning, hopefully around the first week of May. And this one question is, do you have pencil beam proton? And is that what will that popcorn trial be viable for breast cancer in the future? So we do have the latest third generation intensity modulated proton therapy, which is also called pencil beam scanning. That is the latest and greatest technology, and we have that installed here at LCI. The question of whether the popcorn trial technique, which is a pulse reduced dose rate, might be viable in breast cancer, it's a great question, and would be a very interesting one to study. I know that there are proton therapy trials being investigated, not just the RADCOMP trial I showed you, but other trials also being investigated in breast cancer, trying to limit some of those late effects, or for women with recurrent breast cancer who are getting radiation a second time. So there's certainly active areas of investigation in breast cancer and proton therapy. Does insurance impact decision? So that's a great question for proton therapy, and the short answer is yes. So in our health system in the USA, insurance does have a significant influence over what treatments can be offered. And so, insurance denial would be a barrier to being treated. The good thing is that there are appeals processes. So, when the radiation oncologist does recommend proton therapy, but you might get an initial denial, there are appeal processes that we go through, and not uncommonly, and know how to navigate this. And we'll do everything we can to try and overturn that decision. So this is another important consideration, and it's important to have that discussion with your radiation oncologist, whether or not they think insurance will be a factor. Do you have surface guidance for your proton therapy? So the short answer is yes. We use a CRAD device, and so we will have surface guidance. This is a little more talking shop, but it's a great question. And basically, when you set a patient up with proton therapy, you want to make sure that they're in the right position. And we have a lot of different imaging tools and ways to maximize the chance of the patient's in the right position. Okay, so I think those were all the questions that I saw come in.
Let's see, there's something in the chat.
Oh, one last question here.
Oh,
Can
okay.
multifocal left breast cancer be considered for proton if all in one quadrant? So yes. So any extent of breast cancer is that for a breast cancer patient that needs radiation therapy, can be technically treated with proton therapy. The kind of extent of disease in the breast might influence the approach, the technique used for breast cancer radiation. But in other words, there's sometimes we treat more focused, or the whole breast, for example. But in general, for proton therapy, we can still use those same approaches, those same techniques, regardless of its proton or photon. The real question is whether proton might be indicated for breast cancer. The real distinction is if the lymph nodes are involved or needed to be treated, because that is a much more comprehensive treatment. So for most women, fortunately, might have early stage breast cancer, have a lumpectomy, and then need whole breast radiation. In those scenarios, because the target is more contained outside the chest, and we're not trying to reach for those lymph nodes in the center of the chest that lay right over the heart, we often don't need to use proton therapy in those scenarios because conventional X-ray radiation spares the heart so well. If we're not trying to spare anything, or we don't think there's going to be a major advantage, then in general, for a limited resource, it's not expected to make enough of an impact to do that. But if a woman has need for comprehensive nodal coverage, that's the kind of the preferred scenario for proton therapy in the upfront setting.
There is one question in the chat box. Are you able to see that? The
Well,
first one.
that was a follow-up. So she said with no lymph nodes. So in general, again, I would say talk to your radiation oncologist. It's certainly a great question to ask, and they can go into some more details based on your specific clinical diagnosis. But if you're just having the whole breast treated, most likely they will not recommend proton therapy because, again, that target is targetable with X-ray radiation with essentially eliminating all dose to the heart. So at that point, you're already kind of getting the A plus treatment. But there again, there could be certain scenarios where that's not the case. So I would talk to your radiation oncologist and review that with them.
Thank you. In the chat box, which is separate from the Q&A, there is one question. If you can't see it, I can read it to you.
Yeah, if you wouldn't mind.
Okay, earlier a slide showed the progression of proton therapy by location. Many had 3 gantries, and then in parentheses she said, including MCI. Why did we choose to get 1 gantry?
Yeah, that's a great question and very, very insightful to notice that. So, it really comes down to the clinical need and the cost. As I had mentioned, it's a very complex infrastructure capital investment, and essentially those larger centers are very, very expensive. And if you look back at that slide with all the different dates, you will see that the vast majority of new centers are single gantry centers. And so I would say that, we built the single gantry for both the cost, but also that it would fit our clinical need here in the community and our patients that we see. You can always build another one, but you can't take one away. And the other important point is within Baptist Health, we actually have 2 proton centers now, and the primary center at in the Miami Cancer Institute does have 3 gantries. So it is we have still a high capacity for proton therapy in the health system, and so for our specific needs here at Lynn Cancer, the single gantry was the best way to go.
Thank you, Dr. Press, and thank you everyone for your great questions. We all learned so much from you today, Dr. Press, and we're so grateful to have you in our community and here at our hospital. And I think we might all be a little more equipped now to be in the conversation because there are a lot of questions being asked. And to the audience, a few people had asked, yes, this presentation was recorded and it will be edited and should be ready probably by Friday. So if you'd like to look at it again, if you'd like to share it with either coworkers, family, or friends that were not able to make it today, you can contact us and we'll send you the slide or the link to the presentation. And Lee will be sending out the evaluation. So that's a good opportunity to make that request. And we really appreciate it when you complete the evaluation and send it back to us. So be on the lookout for that. And I always like to give you a little update on our next lectures. On March 18th from our nutrition series, it will be Discover the Power of Nutrition by Marie Mirandi, our LCI dietitian. And on March 25th from our physician panel, we will focus on colorectal cancer. The title will be Prevention Starts Early, Understanding Colorectal Cancer Treatment. And I want to thank you, Dr. Press, for joining us and everyone that took time out of their lunch to learn about this amazing technology that we've just added. And we're very excited. And like I said, now we're able to answer a few of the questions to the people in our community. So thank you, everyone. Thank you, Dr. Press.
Yeah, thank you for everyone's attendance and attention and great questions. And we're always available, if you have any questions or need to be seen by a radiation oncologist.
Thank you so much. Bye, everyone. Have a nice rest of the day.